I'm here representing the other end of the age spectrum of shoulder and elbow problems, that is the children. I'm a pediatric orthopedic surgeon, so we will be doing some lateral thinking in lateral condyle fractures of the humerus. So straight away into cases, 6 years old female, some fall, some swelling, able to have some movements. So how would you have managed it? Some would say conservative, some would say operative. It was managed conservatively, and here is the result. Okay, after 6 weeks plaster removal, the fracture is yet to unite and probably it is not going to do so. Another similar looking fracture, but when treated conservatively, it healed beautifully. So something within us is asking the question, what is actually happening? How to make a better interpretation of the fracture lines? So this is what is wrong with the elbow? How would you manage it? Looks innocuous, but it opens a Pandora's box when we see it from the AP view. So let's start some sideways thinking. So Song in 2008 came and he tried to dispel all the noise that was going on regarding lateral condyle fractures, and we see how statistically methodical it is. So this is what a strong Song stage 1 looks like. It's an incomplete fracture line, and that can be safely treated conservatively. As a Song 2 is the structure line is going but not all the way across into the joint line, and Song 3 is the one which is actually going all the way across the fracture line. So how to differentiate between Song 2 and Song 3? If the fracture line is looking like a wedge, then it is eventually going to converge somewhere, hopefully before the fracture, the articular surface begins. So this is a safe one for close reduction and percutaneous spinning, whereas in Song 3, it is a parallel line, so the parallel lines never meet, so it is going all the way across the joint. Of course, arthrogram can be performed, MRI can be performed. Song 4 is clear cut. It is a displaced fracture lateral condyle humerus which warrants an open reduction internal fixation. K-wire parallel to the joint line to restore and stabilize the articular congruity, and a good compression and stabilization across a fracture site perpendicular to it from the metaphyseal aspect. The arthrogram is always important, especially because the large part of the distal humerus articular surface is not seen on the X-rays. Now, we'll play around with the word lateral again. So when the patients go laterally, they do not straight away and with an orthopedic surgeon. So the problem intraoperatively that we come across is that the joints do not seem to fit together, because by the time the joint has become the fragment has become bigger, and the tip is to align the articular part of the fragment and provide a good stability to the metaphyseal fragment, and then post-op how it heals reasonably satisfactorily. Now sometimes the doctors also tend to go a bit sideways. So it is a 5-day-old injury. It was fixed with open reduction internal fixation, but we can see some signature of some struggle. The K-wire has bent and it was removed at 3 weeks, like that of a supracondylar fracture, and needless to say, it came as a non-union to us, and it was fixed with open reduction internal fixation, calumniated cancellous screw, and K-wires without grafts, even though it was more than 2 months old. So sometimes we would feel that as if we are too lateral in our screw placement, and as if the screw head is floating. But as I said, a large part of the distal humerus is not seen on the X-rays, and that's why it is okay to have a part apparently a bit protruding. Now let us go a bit more extreme when the patient presents to us long after the injury. 4 months old, quack treated, and you can see how the limitation of range of movement is there, and there clearly it is warranting an open reduction, internal fixation, and improvement of the range of motion. So here again we try to align the articular fragment as much as possible and give a good compression at the metaphyseal fragment, and he has a bit of lysis on the lateral side, as you can see, but do we really need to be unhappy? Not exactly, because the child is going to grow his unossified cartilage and bone later on, and with an excellent range of movement, of course. Now, some of the extreme cases, 4-year-old injury, 10-year-old female, she comes to us with deformity and some part of instability, but no tardi-ulnar nerve palsy, and this is what it looks like, 33 degrees of cubitus valgus, and then we need to do something. So instead of a standard posterior approach, we can also take a lateral approach. We do the osteotomy, we get one compression screw across the non-union side, nothing much to be done because we want to preserve as much of the range of motion as possible, because she has got a very good range, and at the same time no bone grafts and no ulnar nerve transposition because she has not come with one ulnar nerve symptoms. So the non-union got healed surprisingly without any bone grafts, so that's what it does, and range of motion is also preserved. So there are different options for different situations. It's a busy slide, but it summarizes how we should approach each of those late presenting lateral condyle fracture humerus. So sometimes to take home, lateral thinking helps. Thank you so much.